Chapter 19, our last chapter for maternal child. Newborns at risk with birth-related stressors. This first slide I really want to talk about. You will see in the book hypoxic ischemic encephalopathy, HIE. This is the whole reason, in my opinion, labor nurses are here. This is what we're trying to prevent. The whole time we're watching those contractions, we're watching mom's blood pressure. If baby has a hypoxic event during labor, so many terrible things can go wrong, you guys. If mom doesn't get enough oxygen, if blood pressure's too low or too high, if we have that placental separation, that abruption before baby is born, if the cord is wrapped around the neck, any of these things, this is why the decelerations of the baby's heart rate are taken so seriously. If babies have this hypoxic event, it sets them up for possibly long-term, their entire life problems. A recent, and I say recent maybe in the last 5 years, when babies started having these events, they actually started cooling their heads. So they actually might get them to the NICU, drop their body temperature, and wrap their head in some sort of cooling device, which I'm sure changes constantly. So read this is really important stuff. It starts on page 269. Know what are the signs and symptoms in the infant at birth. This is when we're doing the APGAR scores and it is less than 7. So we are taking some kind of action. This baby is in trouble. Like I said, immediate CPR is provided. These babies usually don't come out not breathing. They might gasp. They might do all kinds of things. It's not just that they can't breathe, it's that they're really in trouble. They have had a hypoxic event. Complications can be cerebral palsy, epilepsy, blindness, delayed motor and sensory development, and learning disabilities their entire life. Respiratory distress syndrome. Read the paragraph on page 270 that starts with respiratory distress syndrome. It is really very interesting. These babies can need ventilation, they might need surfactant dosing, and then they might need CPAP, continuous positive airway pressure. This baby's going to usually get an IV. They're going to be on IV fluids. We're not going to be trying to feed them while they're struggling to breathe, right? So we're going to have to feed them in some way, usually through an IV of some type. Signs and symptoms, you can see them there. The grunting is usually very obvious. I think I have a little video on my Moodle page that you can click. It's very short, of a baby with retractions and grunting. So you can read this medical management. What are we going to do for them? They're going to be in the NICU, like I said. They're going to have an IV. You know, some of this stuff is if it's very serious, if they have to go on nitric or any of these other kind of things. They're usually, quite often, they might even get put on antibiotics just if they don't know what's going on with baby, just to make sure that it's not an infection. This family is going to definitely need emotional support. They're going to be scared to death when they come in to see all this stuff attached to their baby. They're going to need it all explained to them, and you're going to have to encourage them to touch their baby. Don't be afraid to hold their baby. Skin to skin, even with a baby on CPAP. You know, it is so important for that baby to still feel mama and dada's love. Transient tachypnea is possibly maybe the most common, and it's very short-lived. The baby maybe has some excess fluid in their lungs. Maybe with every breath they're taking, it's not pushing it out. So these babies, usually we're watching them, we're supporting them, but it doesn't typically last longer than maybe up to 6 hours. Meconium aspiration, like I talked about earlier, is very serious. The baby can be very ill. So you can read here and in the book what is going on, what are we doing for these babies. This often happens as a surprise. You know, everything was fine during pregnancy. Maybe babies post dates that they swallowed or inhaled meconium, I should say. Maybe not. You know, sometimes it just happens. Usually remember, if a baby has a meconium stool before they're born, it means they were in some kind of distress, and this might be the end result of it. Persistent pulmonary hypertension is a very serious thing also that happens. It can be life-threatening. So this is another very serious thing. They might do that EKG or the 2D echo to witness where the blood flow is going through the heart to confirm the diagnosis. Cyanosis usually persists. The baby never quite pinks up. Sometimes this can be related to SSRI use by the mother. That's why they really weigh whether mom should stay on the medicine or not, you know, depending on how severe her diagnosis is. So this just gives you the signs and symptoms and what are we going to do for that baby. Cold stress. So we're constantly going to be aware of how the infant could be losing heat. You know, what are we doing? Are we unwrapping them? Are they having a lot of procedures? Are they in some kind of cold draft? Is mom undressing them constantly? What's going on? At-risk infants are the preemies or the ill babies, right? We're going to place the baby on warm pads. We're going to keep them in an isolette. We're going to be monitoring their temperature constantly. They're probably going to be getting glucose checks because if they have cold stress, their glucose could be dropping. So this just gives you more signs and symptoms and our interventions. Neonatal hypoglycemia. So we talked about this briefly earlier. I do want you to know these parameters, the 30 and the 45. Risk factors, those are important also. Blood sugar checks are done routinely on infants that meet certain criteria, and they can be done anytime the nurse suspects that the baby might have a low blood sugar. Protocols are in place, calling for the blood sugars every 3 hours until stable, and sometimes they're getting them every hour if they really can't get them up to where they want them. Like I said, sugars are drawn on the baby's heel. So if we have any other labs to do, we have to time them with the blood sugar draws so that we're not repeatedly sticking the baby any more than we need to. There are actually gels available to put in the infant's mouth that dissolve and absorb rapidly if they have a low blood sugar, if we can't get baby to eat either formula or breast milk. That is the ideal thing we want to do, but signs and symptoms of hypoglycemia you may want to pay attention to. Here's a question. Here's an answer. Birth injuries. This starts on page 273. I don't really have anything to add to these slides. I think it's pretty self-explanatory. Medical management obviously depends on the injury. You know, what do we need to do? Do we need to provide pain relief? You know, positioning, protecting the baby when we pick them up because they're held quite frequently, put up and down into the bed. Parent teaching is very important. Nerve damage, remember, can be caused by if they used forceps or anything like that during the delivery. Can be temporary, hopefully temporary, but could be a permanent injury. Remember, we're going to be looking for the symmetrical movements of the face. So anything asymmetrical, we're going to definitely notify the doctor of. Fractures of the clavicle, I don't want to say they're common, but that's usually what happens, especially in a shoulder dystocia. Sometimes that happens, but even just in a big baby, maybe we didn't even notice baby was stuck anywhere. It just might happen. Macrosomia, that means large baby. Usually that arm just kind of hangs there. The other arm might be nice and toned, and what it should be doing, and that arm will just kind of be hanging there. They're going to get an x-ray. Usually we can just wrap it, immobilize it, and it heals on its own. It's a baby. They heal very quickly. Hyperbilirubinemia. So too much bilirubin. This is where the babies get jaundice. Jaundice is that yellowing of the skin and the whites of the eyes. All babies, almost every single baby goes through slight jaundice just because their liver isn't able to manage all the excess red blood cells that they get. So, but some will get jaundice to the point that we need to put interventions in place. So you can see the risk factors there. And jaundice levels are all based upon the history, what the baby's age in hours is, and the gestational age. So every baby that's 8 hours old doesn't have the same threshold when they judge for jaundice. If they're preemie, it's a lower threshold. So it really depends on that kind of stuff. Normal jaundice starts around days 2 and 3, peaks by day 4 and 5, and then starts to go down. Phototherapy is usually initiated. We want to make sure they're eating well. We're keeping them warm. Eating well is going to let them poop more, and that is how they're going to get rid of the excess red blood cells. The body breaks them down with the phototherapy, and they poop them out. If they're under phototherapy, that's an overhead phototherapy, we're going to cover their eyes, and they're going to be in a diaper. So we got to make sure they're staying warm. But most of the skin is exposed to the light. So this one talks about reaching 5 to 6. It really depends on the age of the baby and their gestational age. It does follow in that cephalocaudal fashion, though. It starts in the head, works its way down to the chest. Usually by the time it reaches the abdomen, we start to get worried. So we'll start testing. We can do a non-invasive test. It's a little light that's pressed on the skin, gives us an average of readings, or we can also draw a serum bilirubin. Exchange transfusions is really if they're very concerned. If the number hits in the 30s or gets anywhere close, it can cause kernicterus, it can cause brain damage. Before we knew what was going on, that's what happened. I don't think there's too many babies in America, at least, that have ever reached that level unless someone is just not checking on them. So this is what the nurse is going to make sure is happening. And there are labs on page 275 you can read about. Neonatal sepsis. So starting on page 276. A baby with an infection. The signs and symptoms of a baby with an infection are listed there. They're going to, if we suspect any kind of infection, the baby gets an IV. Ampicillin and gentamicin are typically the antibiotics that we start with. Of course, a culture and sensitivity is going to be drawn before antibiotics are started. And when it comes back, then we will know if those antibiotics are going to cover it. Depending upon how quickly the infection is caught can determine the outcome. Many babies are just treated with the Ampingent as a prophylactic treatment until the cultures come back. Quite often the cultures come back negative and we can stop them after 48 hours. And baby usually will tell us. Their activity, their behavior is going to tell us if they're infected. Babies don't have a lot of reserve to, fight off infection, so they become ill very quickly if they are in fact infected. Herpes is deadly to a baby. They can't fight it off. So that's why if mom has any active lesions, she's going to get a C-section. And if mom developed herpes for the first time during the pregnancy, baby might have a worse outcome. If mom has any active lesions, like I said, they're going to get a C-section. If mom has any kind of rash, sore anywhere on her skin, they are not going to want her to breastfeed. Mom usually is put on acyclovir or some kind of vir drug before and during pregnancy to lessen the outbreaks. We're going to promote care of the baby by the parents, encourage them to touch and hold the baby, change the diaper, etc., anything that they can do. Like I said, we're going to explain all the noises and the machines in the NICU. We're going to include the parents in the care and the decision process as much as allowed. Rounding with the doctor and the team is important, so letting the parents know what time the doctor will be there so they can hear the doctor and the nurses giving report on what they expect and what's going on with the baby. Often the parents can give valuable input into the feedings and the baby's behavior as the baby progresses and gets close to being discharged. This just talks about what we can do for the parents. Definitely support them in this endeavor. Here is a question, and here is an answer.